Okay, so I am excited today to present on the opioid and narcotic crisis, understanding the epidemic. So, opioid and narcotic addiction has been for a long time a problem in the healthcare world, and I hope to touch on some of that today to maybe give you a little bit better of an understanding. Okay, so in this presentation, I'm basically going over an overview of the opioid crisis as a national public health emergency. We're going to talk about the rise and misuse of opioids and narcotics, addiction, overdose potentials, and deaths. Also, the purpose of this is to raise awareness, to understand the history of narcotic addiction and how it kind of started, current data and statistics of what's going on, and exploring prevention and treatment solutions. Okay, so what are opioids? Opioids are drugs that act on the nervous system to relieve pain. They are generally prescribed by physicians when you have an injury or an acute or chronic pain condition or disease. So this can include legal prescriptions that are prescribed by your physician, but also includes illegal drugs where people are getting them on the streets. So some common examples, oxycodone. This is a big one. We're going to talk about it here in a few slides. OxyContin. This was a huge crisis in the late 1990s, early 2000s. And then we have some of the more commonly prescribed medications like hydrocodone. This is known as Vicodin and sometimes Lortab, depending on which pharmaceutical company. Morphine, codeine, fentanyl, and heroin. So, narcotics are generally drugs that help to induce sleep or relieve pain, or both. Okay. A lot of times when we're in pain, we have a hard time sleeping. So, they kind of have a double effect there as well. They're used a lot in conjunction with opioids. Okay. So, this includes both natural opiates that can even be like grown and synthetic opioids that are made either in a pharmaceutical company or on the street. So the DEA has a schedule of drugs that are the most addictive, starting with Schedule 1 all the way down to Schedule 5, which has the lowest potential for abuse or addiction, but still has some. So let's go over that really quick so that we can understand kind of what we're looking at when we start talking about some of these narcotic and opioid medications. So we start with Schedule 1. This has the most potential for abuse and dependence. Now, these ones are not medically used drugs, okay? These are things like heroin, LSD, peyote, marijuana, ecstasy. Now, I know some states have legal marijuana. This isn't the marijuana I'm talking about. I'm talking about marijuana that's laced with other things. So these are not used in medicine at all. They are not prescribed. So these are illegal drugs that you would obtain. Can you guys believe at one point some of these were prescribed, like types of heroin and types of peyote and stuff were actually prescribed way a long time ago, maybe in the 50s, the 1950s. But of course, they started to see the danger with those, so they're no longer prescribed. So that gets us to Schedule 2. And this is the schedule that you will see prescribed in medical offices. They have the highest potential for abuse for medications that we do prescribe. So these are things like Vicodin. These are things like OxyContin. And then you have some of the medications like methadone, okay, that is a form of meth, Adderall, and they have cocaine in there. Obviously, that's not one that's prescribed, but it's still a Schedule 2, and other medications. So a lot of the times when we think about opioids and narcotics and drugs that we become addicted to, we think of like pain medications, but there are other medications like Adderall. Adderall is used to treat ADHD, and people can become dependent on Adderall. It gives them not the same kind of feeling as a narcotic, but it helps them to keep their concentration. It helps them to be able to keep things done. I had a patient one time who was addicted to Adderall. And after we were setting up some help for her, she was telling me, I got addicted to it because I could get my house clean and I could do things and I could focus. So I started really liking that feeling. So a lot of times the stigma behind dependence or abuse of opioids or narcotics, we have this picture in our head, but a lot of everyday people will get addicted by accident just because they're taking it to fix something else. And all of a sudden they're depending on that because it's helping them get through life. Hello. Okay, Schedule 3. This is less dependence or abuse potential than Schedule 2 and 1, but there still is some moderate dependence here. These are things like Tylenol with codeine. We see this a lot with cough syrups that they prescribe when you have a respiratory infection or something. They will give you a cough syrup with codeine. And steroids and testosterone. These aren't really like narcotic type medications, but people become addicted to them. You see gym people that go to the gym to work out and they're super healthy, but all of a sudden they're wanting to look like that person in the gym next to them. So they start taking things like testosterone supplements and steroids to try to get bigger and they become addicted. So it just can happen in any form. And then we have Schedule 4. This is a lower dependence, okay, but still some potential for abuse. And this is a lot of our mental health medications. So our Xanax, our Valium, our Ativan, Ambien, which is a sleeping medication, and Tramadol, which is a pain medication. When Tramadol first came out, it was not considered a narcotic, but because they saw that people were getting dependent on it, even though it was less than the other drugs, they added it to Schedule 4. And then we have Schedule 5. This is the lowest potential for abuse, but they still had to put it on the schedule because there is some chance of having dependence. And these would be things like Lyrica, which is prescribed for nerve pain, Robitussin, things that you can get over the counter in cough medicines that if you take in a big enough dose can have an effect. Okay, so there's always been drug dependencies and drug addictions with narcotics and opioids, but it really started to become a problem in the late 1990s. There was a surge in opioid prescriptions, and we're going to talk about this in about 9 slides. I'm going to share something with you, but something came out called OxyContin, and it became a huge problem with drug addiction and dependency. So pharmaceutical companies like Purdue Pharma, okay, came out with medicines like OxyContin, and they claimed that they were low addiction risk, okay? They were the miracle drug because they could help people with their pain and very little people became dependent on it. These were not truths because people became very dependent on it and it started a huge crisis, more than we had ever seen in any years before. So it led to widespread prescribing, okay, and increased misuse because this company kept raising the milligrams in it because people started to become tolerant to it and they needed more to have the same effect. So this led to a transition to heroin in 2010 because they started really cracking down on OxyContin being prescribed. And because it was no longer readily available or prescribed, people started going to the street for more heroin. And of course, heroin was around before that, but that was kind of what the OxyContin dependent people went to next to try to get that same feeling. So heroin started to become a big problem again, as it used to be back in the early 90s and 80s. Okay, so I don't have the latest statistics of 2025 and 2024, I guess they're still kind of counting. So 2023 is what I've got as our latest statistics. Over 80,000 opioid-related overdose deaths happened in 2023. You know what's really interesting about this, though, is 70 of those 80,000 overdoses were accidental. They weren't trying to do it on purpose, but they were taking the medication and maybe tried to take a little bit more, or they were buying it from the street and didn't know that it was laced with something else like fentanyl, and they were accidental overdose deaths. So fentanyl became a problem. It's still a problem, but it was really big about 5 years ago. I remember hearing about it. I still have kids at home, and everybody was like, if they go trick or treating, look at their candy and all this stuff, because they were putting it everywhere. People were putting fentanyl on dollar bills that were falling on the ground. And of course, you see money and you want to pick it up, and like people were dying. It was in candy, it was in things that you touched, it was everywhere. So fentanyl is implicated in over 70% of these deaths. Maybe somebody got some heroin illegally off of the street and they had taken it a million times before and hadn't had an issue, but this time they got it and it was laced with fentanyl. Lily, let me hit on that at the end. Yes, I agree with you there. Hi there. Hi, hi, hi. But remind me at the end and we'll talk about that. So there has been a six-fold increase in synthetic opioid deaths since 2013. So from 2013 to 2023, it is 6 times more. Okay, so we've really seen a huge, huge problem and uptick here, especially with fentanyl coming into the picture. So prescription opioids. This is how it begins for a lot of people. They're prescribed for acute or chronic pain, okay? And then there is a risk of tolerance or dependence and addiction when you use it prolonged. So some commonly abused prescriptions are oxycodone, or OxyContin, hydrocodone, and codeine. Heroin is an illegal opioid that's made from morphine. It can be grown in poppy seed fields. There's like all kinds of way that people are illegally manufacturing, growing, and processing this. It's actually cheaper and easier to access than prescription opioids. There has been a big crackdown on prescribing narcotics, and I'm going to talk about that in a minute. But because of that, heroin use has increased and it's cheaper to get. I did not know this until I was doing the research for this presentation, because I always just assumed you had to have like a lot of money to get heroin, but you don't. Of course, if you're buying a large amount of it, it costs a lot, but for people that are just getting it for single or double doses, it's very cheap to get, and you don't have to go to a doctor and convince them to prescribe you something. So it's easier to get and cheaper to get. So often heroin is mixed with fentanyl, which increases your overdose risk. It started out that people were lacing fentanyl with heroin because they wanted a better product. People that were taking that heroin would be like, oh, this is way better than other heroin. But it was because it was mixed with fentanyl. But because there is such an increased risk of overdose with just a little bit of fentanyl, people were starting to get really sick, overdosing, and even dying. So fentanyl is 50 to 100 times more potent than morphine, okay? It's actually a medication that can be prescribed, but it's prescribed in very low doses. But often it's illegally manufactured so that they can sell it or lace other drugs like heroin with it. So a small dose, just a very small dose, can be lethal, especially if you're mixing it with other medications like heroin. So this is kind of how it happens, okay? Not with everybody, but with a lot of people. And I think that there's a stigma behind opioid and narcotic addiction that could be wrong for some of us, okay? I learned a lot about this when I was watching different videos, preparing for this presentation, and when I was researching. So a lot of times it begins just like this. You go to the doctor because you hurt yourself. Maybe you got over a surgery, or you fractured your ankle, or you have a chronic disease that causes some pain. And you go to the doctor and they prescribe you some pain medication for it. So a narcotic, okay, like OxyContin or hydrocodone. And if you take it, it helps your pain, okay? And then you're like, okay, I'm still in pain. Let's go back for another prescription. And all of this is being is starting with your physician, and they're saying, yes, you can have another prescription. You may even need to take this long term, but you only need to take it like twice a day or when you're in pain. But all of a sudden, that dose doesn't work anymore. Okay, you're out of pain and everything is going well, and you're like, wow, I can really do this with this pain problem I have. But then all of a sudden, that dose isn't working for you anymore because your body becomes tolerant to it. So you go back and they maybe increase the dose for you and it's working well. And then the same thing happens again. Your body gets used to it, it becomes tolerant to it. And then you go to the doctor and they're like, okay, we're at the highest dose that's safe for you. So I can't go up anymore. So this is what you get, and that's it. And people are already addicted to it at that point, to the point where if they don't take it, they have kind of withdrawal symptoms, okay, that are very uncomfortable. And they didn't mean to get addicted. They took it as prescribed, but all of a sudden they can't go off of it and they need more of it. So then they start panicking and they start getting it from other doctors or illegal places or anything they can do to get rid of the pain. So a lot of times it doesn't start out with you wanting to be that way. It starts out with a broken ankle. Okay, this has been so many stories that I've seen in healthcare and the long time that I worked in healthcare, where they're just regular people. They're moms, they're dads that work every day. You know, they're teachers at the school. They're like people you see every day. There's not necessarily this stigma that we see where it has to be somebody that's living on the streets to be addicted. It can literally happen to anyone. And most of the time it happens like this on accident. So sometimes it can be influenced by genetic factors. If you have addiction in your family, then you are genetically prone to have an addictive personality. Does it mean if your parent was an alcoholic, you're going to be one? No, but you kind of can have that brain makeup and that serotonin makeup in your brain that makes you be a little bit more of an addictive personality. So genetics can influence it. Of course, environment can. If you grow up around a lot of drug addiction and drug abuse, then you're more likely to try it because you're around it, right? And there's a lot of psychological factors, like this one, where you have a pain problem and you just don't want to be in pain. You want to take care of your family, you want to live life, but you don't want to be in pain. So you get prescribed it, and all of a sudden you're in this slippery slope. So this has a lot of impact on everybody when addiction comes into play. It takes an emotional toll on the victim, okay? It causes stress. They don't know what they're going to do. They're afraid. Maybe they're afraid to tell people in their families because they're worried they will leave them. And they have a lot of grief and shame. It's also a financial burden, especially if the addiction turns to buying it illegally, okay? When you're addicted to narcotics or opioids, or really anything, you come to a point, a lot of people have said, where it doesn't matter the cost, you'll find a way, even if it's illegal. And this causes a financial burden, especially if you're responsible for other people. Legal issues can happen. You can lose your employment. You can get in trouble for buying drugs illegally, and you would lose income. You may even lose your house. Okay, people have gotten homeless, lost their children because they were addicted to narcotics and they got put in foster care. So a lot of things can kind of snowball from addiction to opioids and narcotics. So there's also an impact on communities. When we have increased numbers of people becoming addicted to narcotics and opioids, it increases healthcare costs. We see more of them in the ER. We see more of them in the urgent cares, either going through withdrawal or trying to get medications or trying to get a fix, is what they call it. We see rising homelessness because of this impact and the snowball that it causes. Increased crime rates. A lot of times, if people are very, very into their abuse and addiction, they will go to crime, stealing, getting money, or stealing from pharmacies or stealing from people's homes. And a lot of treatment centers and public health services are overwhelmed. So when the people are ready to get help, they've hit bottom. A lot of times there's a waiting list for treatment facilities for them to be able to go to rehabilitation services. Okay, so demographics affected. Every demographic is affected. If you ever had any judgmental pictures in your mind of who would be addicted to drugs, get rid of them, because anybody is. If you go into a big room of like 500 people, it could literally be any of them. And I bet you would be surprised if they were like forced to raise their hand. Like, wow, I never would have thought it would have been you or you. It initially actually hit like the white middle class communities the hardest, okay? But now it impacts all groups, all races, all ages, okay? All genders. There's really no culture or group or age that it does not affect. You will see older people with dependencies. You will see little kids with dependencies. You will see middle-aged people. You'll see people that are wealthy, people that are middle class, people that don't have a lot of money, working people, people that don't work. It's literally could happen anywhere. So don't think that it couldn't happen to somebody, because that's part of the problem, is that we're putting a stigma on it. It really is a disease that can affect any person. They do say in the statistics, and I have references at the end, that the highest overdose rates are in the age group of 25 to 44, although it can happen younger and older as well. Okay, you guys, I told you I was going to talk about OxyContin. So big pharma, OxyContin crisis was huge. How do I know? I worked during it. I actually worked for an office that was affected by this. Let me move this a little bit. So Purdue Pharma marketed OxyContin in the late 90s. It was the miracle drug. It had a low risk for addiction. Okay, they ended up getting in a lot of trouble. They had to pay fines. They faced lawsuits for misleading practices. But other companies were following similar marketing tactics because Purdue Pharma was rich. They were getting billions of dollars from OxyContin prescriptions. Oh, thanks, Lily. Yes, for sure. I worked in an office when I first started out as a medical assistant in my early 20s that was affected by OxyContin. I didn't know much about it then. I just knew it was a medication that was prescribed, but I worked for a physician who was really into being the best clinic around. He wanted more patients. He wanted to see a lot of patients, because when you see a lot of patients, you get a lot of money. So his way of doing that was prescribing it. People were coming from other states because they heard he was somebody that would prescribe it. And it was wild. And long story short, that physician where I used to work ended up losing their license, and the clinic shut down because a lot of stuff happened from that. But it was wild. It was in Tennessee, and we would have people coming from like Kentucky and Alabama. And I'm like, why are these patients driving 3 hours to come to the doctor? But it was because he was prescribing it, and he was doing it to get more patients so he could become one of the bigger clinics in the area, because, you know, he wanted to be successful. And it was just a crazy, crazy ride. I'm going to play you guys a trailer. Okay, it's about 2 minutes long, so bear with me. I think it's really important to this story of opioid and narcotic abuse. So there is a show on Hulu that came out about 3 years ago. It's called Dope Sick. It is the story of the OxyContin crisis. I remember when it came out, I'm like, ooh, I want to watch that. And I watched it. It's about a 10-show series. It's only like 10 episodes. And it's all about that. And I'm like, oh my goodness, I worked in that. Okay, but this is just this trailer really shows you how bad this OxyContin problem was. So bear with me here. I'm going to play this.
People all across this great nation are in pain. They have hard lives.
Are you still sore?
I can't work here no more.
I'll be all right.
And we have the cure. This new miracle drug, OxyContin.
You will be the largest sales force in pharmaceutical history. Make your doctors feel special. Take them to expensive dinners. Bribe the receptionist with a mani-pedi. whatever it takes to win their trust. Your most effective talking point are these magic words.
Less than 1% of people get addicted to OxyContin.
That's not possible.
I can't live like this anymore.
I'll start you on this. Call on a miracle drug. You only take 2 a day.
I think I can make this the biggest drug in the world.
You think maybe that medicine might be just a tad more addictive than you said?
That's not what we're hearing.
Something is happening here. There might be a unique situation brewing.
A pharma company is lying about their medication.
We have to go after the makers of OxyContin.
My patients trusted me. I can't believe how many of them are dead now.
We're going to do everything in our power to make sure justice is served.
We're going to cure the world of its pain.
Oh, it was so good. If you guys haven't seen it, check it out. Dope Sick is what it's called. But OxyContin was advertised as a pain medication that was not addictive. It was an extended release, so you only had to take 1 to 2 tablets a day, and it started out at 10 milligrams. People started getting tolerant to it, so they would have to take a second one for breakthrough pain. Then they came out with the 20 milligram tablet and the 50. I think they went all the way up to 100 milligrams, and people were going nuts. They were getting addicted to it. They were breaking into places. They were stealing it. They were going to pain clinics, all kinds of stuff. So it became a big, big, huge problem, which then led to the heroin problem when they stopped readily prescribing it.
People.
Right? Okay, so the government, the CDC issued new prescribing guidelines, mostly because of the OxyContin crisis. Okay. So they passed laws to improve prescription tracking. So whenever you got prescribed a pain medication or a narcotic, you had to go through very, very strict rules, and you still have to, okay? And it's all stemmed from the OxyContin crisis. Now, if you're prescribed a medication like a narcotic, if it's just for a few days because you injured yourself, they're pretty lenient about it. But if you ever need another prescription or a refill, or if you need to be on it long-term for a chronic problem, you have to see a pain specialist. A lot of doctors won't even prescribe it at all because they're so scared of getting their license taken away. When you get prescribed this medication, if you're on it long-term, you have to get it prescribed by the same physician, get it filled at the same pharmacy at the same time every month or 2 weeks or whatever your schedule is. If you go to a different doctor to try to get it, or if you pharmacy hop, it lights up in the system and they have these new tracking things for prescription that will let the initial prescriber know that you were trying to get it somewhere else. So they are pretty serious about it, and it's been a great way of controlling some of these prescription issues that are going on. There is a medicine called naloxone. It's Narcan, okay? And it's become popular because it can reverse opioid overdoses. It comes in a nasal spray or an injection, and sometimes people are using it to get off of narcotics, okay? And it's been successful for a lot of people. It's saved a lot of lives. So I'm hoping that they come out with more things like this that are readily available. Okay, so there's also things like medication-assisted treatment, okay? And it's where they combine medication with behavioral therapies to help people get off of their dependence on narcotics and opioids. The problem with this is they give medications that help come off of that drug, like methadone, okay? But a lot of times people that are addicted to narcotics, when they go on methadone, they'll get addicted to methadone, okay? It's like less addictive, but it's still that potential for addiction. But it's helped lots of people. I think it just kind of depends on the person and their particular story on what would work. But it does reduce opioid use. and it improves retention in treatment and people staying in treatment. So some prevention strategies are, we need to make sure we're promoting education campaigns for youth and adults. When I was in school, which was like in the dinosaur ages, I remember they always had drug seminars and stuff where you would go to the gym and somebody would talk about drugs and things like that. And I don't feel like they do that as much. My kids that are in school, I don't feel like they ever have those classes or where they take them to the gym and give them like a little thing on drugs or whatever information on that. And I wish they would bring that back, but they also need to have it for adults as well. We need to make sure we're monitoring prescriptions, and they're doing this a lot in clinics. A lot, like I said, a lot of doctors will not even prescribe it. And you'll have to go to a pain specialist to have it prescribed. Also, something they're doing is if you are on a narcotic medication that's prescribed, they drug test you every time you come in because they want to make sure you're taking that drug and you're not just getting it to sell it. So they have done a lot of things to try to improve abuse from narcotic medications. I've only heard of Narcan used in emergent overdoses. Yes, Lily, they are starting to use it in more than just like ER settings. They're starting to have it readily available for people so that they can start taking it when they're trying to come off of the narcotic. They have to be off of the narcotic for like 2 days or else it can be bad for them. But once they're off of it for 2 days, they can take it and it will kind of help reverse that opioid feeling and it will help them come off of it. It's not like completely easy, but it makes it a little bit easier. So healthcare providers need to have proper prescribing practices. They're already doing this. Legally, they have to, okay? So they have to make sure that they are signing a pain contract with their patients or referring them to a pain specialist who will do that with them. We need to be recognizing signs of misuse. If you're working in the healthcare field and you have patients that come in and they're constantly coming up with excuses like, well, I lost my prescription, or I was taking my prescription and it fell in the sink. If they're coming up with these a lot, okay, sometimes those things do happen, but if it's like every time, then this could be a sign of misuse. We need to have tools in place for our patients, okay? We need to have places we can refer them to for treatment, numbers that they can call, and things that they can depend on from us. So that way we're kind of giving them the tools that they need to at least get started with trying to find some treatment. And we need to educate our patients on the risks of narcotics. When you prescribe them, even if it's just for like a couple of days because somebody hurt their knee, you need to let them know you can become addicted to this. You need to be very careful. And talk about alternatives, okay? Like there's over-the-counter medications. They may not help as much, but there is help there that they can try to use instead of narcotics. So schools and communities, like I said, I think schools should be doing more seminars and things for kids about drug addiction. So they should be implementing it in the curriculum like they used to when I was younger. I think it should be more known in the schools, especially like middle school and high school. If you guys live in a community that has a community center, you could even be a part of hosting support groups, okay, or educational seminars for people. And having access to mental health services is a very, very good tool as well. Mental health has been shown to be something that we're promoting, that it's normal to have mental health help or mental health issues where you might seek therapy or counseling. And I love that they're doing that. A lot of workplaces do that as well. So we just need to continue promoting that. And if you are hosting webinars or doing support groups or doing stuff at your community centers, having stories of people that have recovered successfully is always a good idea. Even sharing the sad stories of families that have lost loved ones to overdose. Okay. These stories kind of humanize the problem and it helps to promote understanding. We need to get rid of the stigma behind narcotic abuse. You're not a bad person because you are addicted to narcotics. But it can happen to anybody. So addiction is often seen as a moral failing. Okay, people are afraid to say they have a problem because they're afraid of being judged. Okay, and then they think, even if I do overcome this, people are only going to remember that. So we need to make it like we are with mental health, and we're telling people it's okay to go get therapy if you have mental health issues. We need to be doing that with addictions, with alcoholism, with narcotics, with anything, because it is considered a disease of the brain. Okay, it's not a lack of willpower. A lot of people that aren't addicted to something will say, it's ruining your life. Why don't you just quit? People that are going through that, sometimes they can't. They actually have a disease that's keeping them from quitting. So we need to reduce that stigma, encourage people to know that they are supported and loved, and that we are here for them to help them find some treatment centers or something that's going to help their situation. So what can you do as a future healthcare person or a current healthcare person? Recognize those signs of overdose, okay? Have a safely disposable place for unused prescriptions. The doctor's office I used to work at had this bin where you could bring in a prescription that you weren't using anymore, and it could be taken care of, and there was a facility that would come and get them and they would dispose of them. Okay, so you don't have to worry about having it in your house. Advocate for education in schools, communities, treatment access, treatment facilities, and support those in recovery. They're more likely to be successful if they know they have support rather than judgment. And then finally, this is my list of references. You guys are welcome to look up any of these that you like for the information that I got today on our webinar. So I am going to stop sharing and go to the chat and see if we had some questions. So Lily said earlier, is there a distinction in how to provide care for dependence addiction that stems from life habits like the Adderall example compared to the other drug dependence? So I think everybody's story is specific to them. And I think what works for one person may not work for somebody else. But I think it definitely matters why they're addicted. Okay. Like the story I shared with the young lady who said, I have ADHD, and when I take Adderall, I'm able to clean my house and I'm able to focus. And I wanted to keep that feeling because I wanted to be a better mom, right? That makes sense to me, but she became an addict from it. So maybe getting some mental health therapy that focuses on why she started it in the first place can help her with that. So I definitely think it needs to be an individualized therapy. Find out why the person got started, what happened, and then work on those issues that got them started in the first place. So let's see, what else do we got here? Yes, we definitely need to destigmatize addiction, because a lot of times, like I said, it happens on accident. You never start off thinking you're going to be an addict. I've only heard of Narcan uses. Yeah, we talked about that in the emergency room. Yes, it can be used in conjunction with other therapies to help with the addiction part and to get off of the narcotics. How do you gently refer them to treatment? So I think that it depends on what your role is in healthcare. As a medical assistant, when I was working in clinical care, I could talk to the physician and the physician could point them in the right direction, and I could give them the materials, websites, brochures, phone numbers, and those kind of things. So I think it's important to know what your role is and what you're allowed to do. If you are a provider, okay, then you can gently say, okay, I think you have a problem and let's get you some help. As a medical assistant or whatever it is you guys are going to school for that are here, that are students, then it's just really important to know the policies in place. We're not technically allowed to say, hey, you need to go get help, but we can work in conjunction with our providers and our physicians on letting them know that you see these signs and that you want them to be aware of them. Because a lot of times physicians might not see the same thing. They get busy, and that's kind of our job to kind of look at those things they don't see. Let's see. And what are the best ways to help in prevention through education, especially in adult populations, to reach many communities? So in the last several years, mental health access has had a big push. They have helped to normalize it in a lot of workplaces. I know where I teach, we have a whole company and human resources that is there for mental health help. They're like, if you need therapy, no questions asked, we'll help you find one, or we've got somebody in our company. I think they need to do the same thing with addiction, okay? Addiction is supposed to be followed under HIPAA, where if you go to get treatment, you don't have to tell like your workplace or whatever. You can just go get that freely without worrying about that judgmental. But I think workplaces need to be promoting like these trainings once a year, okay? Just like we have to do trainings for keeping our information private and all the things we have to do every year. I think they should include this abuse, because it happens. We get dependent on things like alcohol or drugs, or we have mental health issues, and we just need to destigmatize it. But for adults, that's the way I would go. Have it in workplaces, have it in communities, promote it in communities, and then bring it back to the schools. Okay, any other questions, you guys? These are great.
Hi, Jolene. I do have a question. From your experience where patients might over-exaggerate or overestimate how much pain they're in order to get additional medication, what methods of assessments or resources can you provide in those instances where you're not over-prescribing, but also acknowledging that a patient might be in pain, but not in as much pain as they're saying?
Well, luckily, a lot of the laws that have been passed in the last few years on prescribing narcotic medications helps us there. As a medical assistant, when I am interviewing my patients, we do the pain scale, okay? And of course, pain is subjective, so it's different for everybody. If you have somebody that's been in often, or you see a pattern there, then you can keep that in mind for your physicians. But a lot of times if physicians feel like this is something where there's an abuse going on of this medication, then they can refer them to pain management, which is kind of what they do. If you have to be on anything longer than a week, you get referred to a pain management specialist, and then that allows them to run that and handle that. And they are very strict, the pain management specialists. They will say, this is how much you're getting. This is how many times a day you take it. You can't have any more than that. You can't get it filled early. You have to get it filled at the same pharmacy, same doctor. You can't doctor hop. You can't pharmacy hop. And they have to sign a pain contract and do urine drug screens. So it kind of puts it in their hand, which is kind of where we're moving. Pain specialists for narcotic prescriptions, unless it's just like a 1 week prescription for a hurt knee, or you had surgery, so you need something for a few days while you recover, or something like that. So they've kind of taken it out of our hands. But I just think knowing those signs, talking with your providers and saying, hey, did you notice that they were in here 2 weeks ago or last month and they had the same thing, or they used this excuse at the last appointment, and just helping to make your providers aware of any potential misuse signs that you see.
Thank you.
You're welcome.
A question that asks, what's the difference between an opioid and narcotic?
So narcotics are used to relieve pain, and they are used in the nervous system. Opioids are kind of like narcotics as well, but they are like added chemicals or materials that are used in conjunction with the narcotics. So OxyContin is considered an opioid because it combines like morphine with codeine and other things. So that's kind of the difference between the two. But the lower ones, like just codeine, would just be a narcotic. It doesn't have the other chemicals added. If there is someone who may be addicted that approaches you and asks for help, what's a good resource to keep in the back of our mind that we can point them towards in addition to encouraging them? So, Miguel, that's a good question. I think it's always important to have tools in your back pocket. So when you're working in healthcare, have those tools available, which is going to involve some research. So I always like to research. I live in a very small town, so there's going to be nothing here. My next biggest city is Nashville. So I research places in Nashville, treatment facilities, call them, ask them what they provide, ask them if this is something that we can refer our patients to, and have all of that in hand. Ask them if they can send brochures that you can have at your office so that you can readily pass those out that day. That day they're having a problem. You don't want to say, well, I'll have my front office person come up with some resources. You want them to walk out with those resources. So be prepared, like get your stuff together ahead of time, have some information and some materials for them to go home with. All right, any other questions?
I do not see any questions on my end, so just want to thank you again, Jolene, for your time today, and hope everyone on the call got something valuable. If you are interested in joining future webinars, feel free to click the link in the resources tab that will take you to our events hub for upcoming events. I don't see any questions at this time, so we can close out now. Thanks again for your time and hope to see you all at the next webinar.
Thanks, everyone. Don't forget about watching Dope Sick. It's a good show. See you later.